Good morning, good afternoon, and good evening, everyone. I'm Jack from Wisonic Medical. Welcome to join this global webinar of Wisonic 39 College. This is a platform for sharing and learning more about the latest research and expertise of regional anesthesia, pain management, and intensive care. Today, it is really my great honor to again invite Dr. Andrea Tognu to be here as our speaker, and Dr. Ilaria Pacini to be our moderator. And today, I will be the host of this webinar. Firstly, I would like to share you some details information about the background of our speaker and the moderator. Our speaker, Dr. Andrea Tognu, he is graduated from the University of Bologna in Anesthesia, Critical Care Medicine, and Emergency Medicine. Since 2007, he is currently working for Orthopedic University Hospital, recently focusing his interest in pediatric, thoracic, spine, and joint replacement surgery. In 2011, he started the ultrasound-guided pain therapy service for orthopedic pain management. Dr. Tognu organized between 2010 and 2019 over 50 courses on ultrasound-guided techniques in regional anesthesia and vascular access, with over 800 anesthesiologists were involved in. Since 2009, he's tutor at the Anesthesia and Intensive Care Postgraduate School of the Bologna University, a tutor in the National School of Ultrasound in Pain Therapy, Ultrasound Italian Society, and a member of the ESRA Italian Chapter Board, elected as incoming president for 2020 to 2023. Between 2007 to 2019, he was invited as a speaker at more than 200 national and international congresses, including the SORA World Anesthesia Congress in Dubai in 2010, and the 12th the SORA Annual Symposium on Anesthesia, Regional Anesthesia, and Acute Pain Management in New York, September 2013. And at the first SORA Middle East Symposium on Regional Anesthesia, Pain, and Perioperative Medicine in Abu Dhabi, 2015. He was involved as a teacher in more than 100 workshops and cadaver workshops on ultrasound-guided regional anesthesia techniques. He published 15 papers, and in 2010, the book entitled Ultrasound-Guided Techniques in Regional Anesthesia with Elsevier Mawson editor. In 2013, with the same editor, he published a second book on ultrasound-guided techniques in anesthesia and pain therapy. In 2017, ultrasound-guided peripheral nerve blocks, basic to advanced. Dr. Tognu enjoys his family and nature. He believes that in life we have to make a difference. People that know him well say he's a literal singer, creative, hardworking person. He shows maximum respect to the senior people that directed him in life. He aims always to be part of the hardworking group and try to promote excellence. And Dr. Ilaria Pacini, our moderator today, he is a full-time consultant anesthesiologist at the Unit of Anesthesia, Intensive Care and Pain Therapy, Department of Obstetrics and Gynecology from Santa Sola, Pacini University Hospital from Bologna, Italy. In the past, he had several times cooperation with Dr. Tognu for scientific publications. So, for the first section, let's welcome Dr. Andrea Tognu to have his time for his course, fast-track anesthesia in total knee replacement. Welcome, Dr. Tognu. Now it's time for you.
Good evening to everybody. Nice to meet you again, Jack. Thank you a lot for this very nice invitation. Quite very pretty presentation. Thank you very much. And thank you to Wisonic. Hello to the moderator. Ciao, Ilaria. And let's go to speak about our argument. Just 1 second. Here we are. Can you see?
Yes.
Okay.
Yes, we can see it.
Yes.
Okay, thank you. Thank you again to Wisoni for inviting me in this webinar. And this is Rizzoli Institute, the hospital where I'm working since 13 years. And it is, in this picture, he's very well represented, but he's an hospital 125 years old. It's the most ancient orthopedic hospital in Europe. And I'm very proud to work there because innovation and experimental news are always available for us independently to the evolution of the techniques. We are in confidence with all the progression of medicine, and in particular with anesthesia in orthopedic surgery, in all the orthopedic fields. This is our bibliothèque. Here inside, we can breathe the ancient culture, the spirit of the Institute. And this is a bibliothèque from the 16th century. So you can imagine what a sensation you can have studying inside of this bibliothèque. Here we are, knee surgery. Everybody knows how is innervated the knee articulation. It's a simple innervation, mostly based on the pertinence of the femoral nerve and the ischiatic nerve. There is a little component of pertinence of the obturator nerve. The obturator nerve is fundamental when anesthesiologists decide to plan a total anesthesia for the knee articulation, just based on peripheral nerve blocks. So we will be able to see how many possibilities we can get to plan our anesthesia strategy during the operation on the knee. So since femoral and ischiatic nerve are basically the most important nerve innervating this articulation, we have available 3-4 peripheral blocks to plan our strategy. The femoral block, the obturator nerve block, the lumbar plexus block, the abductor canal block, and these 4 peripheral blocks are involved just for the anterior component of the knee. For the posterior component, we have to treat the ischiatic nerve, or we can perform the IPAC block, the IPAC block. Literature is very clear in assert that pain is fundamental, well treated with peripheral blocks. Everybody, or each of us knows very well that the best kind of anesthesia for a total knee replacement or for the surgery of the knee is the spinal anesthesia, a simple, safe technique, but it has several limitations. First of all, we cannot perform spinal anesthesia if patient is under antiplatelet or anticoagulation therapy. And the second problem is that a spinal anesthesia has a limitation in the postoperative analgesia. So we can quite combine a spinal anesthesia with peripheral nerve block, but we will see better on this presentation. it's very important to achieve a good, to give a good quality of life, to guarantee a good quality of life in the postoperative period for patient that is candidate for total knee replacement. And it's very important, the quality of life also, moreover, when we are speaking about fast track anesthesia. You know, fast track means a track, a planning, a multidisciplinary planning finalized to achieve the best recovery after surgery. So what we can call quite worldwide the enhanced recovery after surgery. The fast track planning is, I repeat, co-specialist planning that achieve a very good ERAS, enhanced recovery after surgery, in this kind of operation. What is the matter? What is the issue with this technique? Sometimes patient in postoperative period falls. The falls in the ward is not so rare, and this is the matter. Do we have available such a technique that can prevent this complication in the ward? We have. So ultrasound guided peripheral block are absolutely the first choice in our anesthesia planning. The peripheral block, but we can, as before I told, we can combine quite easy a spinal anesthesia and a peripheral block. We will see better when. Which is the most represented, most executed block when we are talking about total knee replacement is the femoral nerve block. The femoral nerve block is a very easy block to perform, even for the neo specialist. So the beginner, a beginner can quite easy get in confidence after a several 12 procedure performed by its own. It could be able to get a safe technique and to get an effective result in performing femoral nerve block. Just take a look to how we can perform quite easy this block. It's very simple because it is a superficial nerve. So laterally to the arterial, to the femoral artery, we can find quite easy the nerve. And through the in-plane access, we can inject an amount of local anesthesia, an amount of local anesthetic just behind, inside the fiber of the nerve or around the nerve itself. We have available, of course, the out-of-plane technique also, up to the anesthesiologist. I always say that the best plan is the plan which we are in confidence with. So the technique that every one of us is able to reproduce is the best technique. Out-of-plane approach is quite easy, in-plane approach, and it's very important. Often happen this debate, single nerve block or continuous nerve block. In my opinion, for this kind of surgery, is very useful to place a catheter in the femoral nerve, because everybody knows that the knee prosthesis, knee total replacement is a very painful procedure. Moreover, after 48 hours from the operation, since the operation time. That's important to plan a good strategy, a good multimodal analgesia for the postoperative period. And in my opinion, the continuous femoral is very well done if chosen as a primary strategy for analgesia in the postoperative period. The matter is, how can I place a good femoral catheter? Most of anesthesiologists, sometimes, often, place a catheter in the same way as if they were performing a single shot technique. That's a little difference because, you know, if we will try to place a catheter in the same place when is performed the femoral nerve single shot technique, we will for sure will have a dislocation of the femoral catheter as soon as the patient will able to fold his own leg. And that's important because we aim that patient will be able to walk just in the first postoperative day. It's easy to understand how a patient that tried to get up and walk with a catheter positioned in the place when where anesthesiologists usually perform the single shot technique, it would be a short-living catheter. So the dislocation of the catheter is very probably to happen. A little peer to place a femoral catheter while working also in the fourth postoperative day is just a simple trick. We have just to rotate the probe as soon as we have a good visualization of the femoral nerve. Once we got a good imaging, we can find the right point to introduce the needle just far away from the point when patient fold the leg. And this is a portion of acute portion that gives stability to the femoral catheter. And that's very important, in particular, as the patient has to begin in a very fast period the rehabilitation program. And it's very simple. You know, when we have this kind of imaging, we can leave the catheter, we can leave the needle by its own. The needle, it is so stable as the catheter will be in the postoperative time. In this imaging, the amount of local anesthetic is injected just beside the femoral nerve. And we have the opportunity to perform all the procedure in ultrasound guidance. So we have the opportunity to see the tip of the catheter exit from the needle, from the tip of the needle. And that's important because, you know, everybody of us knows very well that the tip of the catheter has to exit the tip of the needle just in 1-2 centimeters. Otherwise, the working tip will go far away from the nerve that has to be blocked or analgesied. And this is a schematic illustration how the technique performs. So once we have a good visualization of the nerve related to the needle, we insert the catheter and we remove the needle. So we are able to understand where the catheter is and if it needs to be retracted 1 centimeter, for example, or less, like here. And after the positioning of the catheter, this is the important aim we have. You can see in this picture how patient is able to fold his own leg without the risk of malpositioning or dislocating the femoral catheter. Factory has developed also this kind of device. Actually, we have available the catheter over needle devices. Catheter over needle means that the catheter, it is placed just above the needle. So is the perfect solution to treat a continuous peripheral block, achieving the certain position of the catheter at the end of the procedure. You can see here how the anesthesiologist is able to remove the needle on which the catheter is on. And after the needle removal, the catheter is placed right where we are looking at. Sorry, okay. Once we have treated the femoral nerve, in planning our anesthesia strategy for knee surgery, from a simple arthroscopy till a total knee replacement, we have to involve the obturatory nerve. Why? It's important because the obturator nerve got the innervation of the medial aspect of the knee, and in particular of the medial aspect of the meniscus. It's very easy to block the obturatory nerve. I go on. We can find quite easy typical imaging where there is the longus adductor magnum muscle, and the pectineum muscle, and the brevis adductor muscle. In the space between these three muscles, run the obturator nerve, not more divided, but is kind of fascial block, because in this region of the leg, the anterior and posterior branches of the obturator nerve runs quite close between them. And this is a specific point, ultrasound landmark, to achieve the obturator nerve block. We can see in this imaging the abductor magnum muscle, pectineum, and in the confluence of the three sepimentum, we are able to inject an amount about 5 ml, not more than 5 ml of local anesthetic. And is enough to achieve anesthesia in the dermatomes of the obturatory nerve. Like in this imaging, we can see. After having anesthetized the femoral and obturator nerve, we have to complete the anesthesia management, anesthetizing also, treating also the sciatic nerve. The sciatic nerve is very important because it confers the innervation of the posterior aspect of the knee. We have several approaches to block this great nerve. It's very important to perform the best one in relation to the kind of surgery we have to approach. You know, the sciatic nerve can be blocked from its emergence from the greater ischiatic foramen till to the popliteal fossa. And is right in the popliteal fossa that we have available also another strategy to treat the posterior component, the posterior aspect of the knee. And it is the EPAC block. EPAC is an acronym that means interspace between popliteal artery and capsule of the knee. This is a compartment block that give the analgesia for the posterior part of the knee, avoiding the motor block. So the first concept we have to be in confidence is that EPAC block is not an anesthetic block. It's just an analgesic block. Because of course, if we perform the EPAC block together with a femoral nerve block and the obturatory nerve block, is not enough to confer the anesthesia for the knee. So EPAC block is an excellent strategy that anesthesiology can associate to a spinal anesthesia. And in the next part of the presentation, we will see also another very interesting block for the management of the analgesia in total hip replacement, or in the more generally in the knee surgery. Here we are. The sciatic nerve, if we cannot perform a spinal anesthesia and we decide to treat the surgical procedure just with the peripheral blocks, where we have just anesthetized the femoral, the obturator, and now we will perform the anesthesia on the sciatic nerve. With these 3 nerve blocked, we confer total anesthesia for the knee. And do we need in continuous to perform in continuous the sciatic block? No, it's not necessary. Is over-treatment in speaking about peripheral block. The one that can be executed in continuous, is just the femoral nerve. The sciatic nerve doesn't need to be performed in continuous. Moreover, since we have available the EPAC block. And a very good approach to the sciatic nerve, we saw before in other slide, that we have available many ultrasound landmark to perform this block. But one of the best, because block also the cutaneous part of the femur, is the parasacral block. The parasacral is a deep block, so we need to perform it with a curved array, so with a convex probe. It's very important to know this approach to the sciatic nerve, because it covers in the best way the sciatic nerve, and it confers the perfect anesthesia if we want perform our anesthesiologic plane just in performing peripheral block for the knee surgery. How we can manage this kind of block? It's very easy, because we have available such a clear bony landmarks represented by the iliac wing. In this imaging, we can see the scan, the ultrasound scan of the iliac wing. As soon as we will say solution in continuous, a discontinuous part of the iliac wing represent the greater ischiatic foramen, from which exit from the pelvis the sciatic nerve. And this is quite easy to understand. The sciatic nerve. How we can approach the nerve? We can approach as usual in plane or out of plane. Up to you, which could be the better approach. Up to the anthropometric morphology of the patient, up to the body mass index, and is relevant the type of patient we have available. And now that we explain how many techniques we have available, so femoral, obturator, ischiatic, we have another important block to get in confidence with, to afford the total, the major knee surgery. And this block is the lumbar plexus block. You know that if we perform a lumbar plexus block in association to a parasacral static nerve block, we can achieve this kind of anesthesia, not analgesia, this kind of total anesthesia. So we can confer to the leg an anesthesia of the total of the leg from the great trochanter to the toe of the foot. Just combine these two techniques. And which is the best approach to the lumbar plexus? We have several approaches, but one of the best in literature is the Shamrock approach. The Shamrock sign is very useful ultrasound landmark to get in confidence with, because it allows the anesthesiologist to perform this block in a very safe manner, from the pediatric patient till the very old patient. It's very important. This is a deep block, so we have to have well clear in mind the anatomy of this deep portion. So in this imaging, we can quite easy see the lumbar plexus, the great vessel anterior to the vertebral body. In yellow, we can see the board of the lateral board of the vertebral body, and up to the lateral vertebral body, there is the lumbar artery. That is the only dangerous anatomic structure to avoid in performing this block. And it's quite easy because we need just to stay lateral to the lumbar plexus nerve, like in this representation is explained. This is a pediatric example. I propose you this video because it's very, very simple to understand. In pediatric, it is always more easy in ultrasound. And that is the lumbar root, maybe L4 root, quadratum lumborum, transversus abdominal plane, lateral board of the vertebra. This is the intertransverse space across which the needle is able to pass. The same imaging explained in this picture. Here we are in an adult patient. So the same imaging, it can be explained as the same in the adult. Quadratum lumborum muscle. This is the lumbar root. For the first time, we are performing this technique. Of course, let's use the dual guidance combination. So the best way to confirm our nerve structure is the nerve stimulation technique combined to ultrasound view. Okay. And here the lumbar plexus is performed in continuous just because we are treating a cancer surgery patient. And you can find quite easy the easiest way to place a catheter in ultrasound guidance, switching the hanging needle technique. So the needle enter in the flank for many centimeters. These centimeters can get a very good stability, both to the needle and to the entering catheter, and the same stability is achieved to the catheter in the postoperative time. Of course, we have to be clearly in mind that are different approaches, the anesthetic management of the cancer surgery than the elective total knee replacement. So we have available different techniques up to the kind of surgery we are involved in. And this is the AMI concept. It's very important, and it is a consequence of what I was explaining right now. There is a very enthusiastic fermentum about the fast track surgery and the fast track technique, the ERAS enhancement surgery after surgery, the recovery after surgery. But we have to have in mind that after surgery, there is an important arthrogenic muscle due to the traumatic surgery. The surgeon is obliged to cut tendons, to break bones, to cut muscles, and we cannot pretend that these tissues gonna recover in a few hours. It's very important to have clear in mind which kind of surgery is performed. Of course, if we have to manage the best anesthesia strategy for a total knee replacement, as I told before, one of the best techniques is the spinal anesthesia. Spinal anesthesia, if it can be performed, is a very good strategy. Its only limit is the lack of analgesia in the postoperative time. We saw before how the femoral catheter works very well for the anterior part of the knee, and how the EPAC block works for the posterior part of the knee. Which is the limit of the femoral nerve block? Is this. That's the limit. Patient is not able to walk very well because of the loss of strength of the quadricep muscle, the quadriceps muscle. And this is a side effect that scare a lot the surgeon. But up to you. We can resolve this problem with a device that can give stability to the knee. Or we can manage in a different approach our anesthetic strategy. We can perform not the femoral nerve, but its own prolongation, that is the saphenous nerve. The saphenous nerve is the prolongation, is a branch of the femoral nerve. It's very easy to perform because it's almost superficial. And we have just to scan the middle part, the middle aspect of the leg, following the track of the femoral artery. By this way, there are the specific muscle ultrasound landmark to detect the real adductus of the abductor canal. In this imaging, we can appreciate scout scanning of the medial aspect of the leg. And we can see the longus abductor muscle, the saphenous muscle, the femoral vein, and the deep femoral artery divided. That's important to understand where is the vascular structure, and moreover, to understand this point. Sorry. The point in which the longus abductor muscle touch the medial aspect of the saphenous, of the sartorius muscle, detect the beginning of the adductor canal block. Okay, why it is crucial to detect this aspect of the adductor canal block during the performing adductor canal block. It's very important to detect this aspect because in the adductor canal, the only nerve running inside is the saphenous nerve. It means that we are really performing the adductor canal block. We will get just a sensitive block with a total motor sparing. Instead, if we inject the local anesthetic volume just before the beginning of the adductor canal block, we will have a motor block after the end of the spinal anesthesia. And this is not our aim because, on the contrary, anesthesiologists perform the adductor canal block just to achieve a very good analgesia regimen, achieving a totally motor sparing of the quadriceps muscle. That means the patient is really able to walk after the procedure from a simple arthroscopy, from a simple knee arthroscopy till a total knee replacement. Let's take a look to a simple case how we can perform this adductor canal block. Here we are looking for the contact between the medial aspect of the sartorial muscle, both of the sartorial muscle and of the abductor longus muscle. And let's detect the beginning of the adductor canal. Through the in-plane approach, we are able to inject local anesthetic volume just inside the abductor canal and then anesthetizing just the saphenous nerve by this way. It is supposed to be the saphenous nerve inside the abductor canal. So the ultrasound muscular landmark is medial in this imaging. The nerve is always lateral to the femoral artery. And this is the spread of local anesthetic just inside the abductor canal. It's very important it's crucial to detect really in a very well manner the tip of the needle because we are very close to the deep femoral artery in performing this kind of block. Another example. For example, this is a day case surgery knee arthroscopy. And if we perform a spinal anesthesia, for example, with a short-acting local anesthetic like prilocaine, and we combine an adductor canal block with 20 ml of a long-lasting local anesthetic, we can have this result. After half hour, patient can walk quite easy without pain. And this is in the afternoon, after 6 hours, he can be dismissed without motor block and without pain. That's important. He's very able to walk and to get along by itself. The same procedure can be performed for the major surgery, for the total knee replacement. In this case, we can place a catheter in the abductor canal block. That's important. We can combine an IPAC too, and we have just performed the spinal anesthesia. This is the result. As soon as the surgery ends, patient is able to move its own leg because usually we inject a very low amount of bupivacaine, 6.57 milligrams, and that's equivalent 2 hour and a half time of surgery, anesthesia for surgery. So anesthesiologist has to be clever to predict the duration of the surgery. Of course, nobody takes care if the anesthesia will take 3 hours instead of 2 hours. The important is that after the release of the spinal effect, patient will be able to walk and to start his rehabilitation program as soon as he can. The technique is very simple, and this a colleague of mine from another hospital in Italy, very happy as soon as they were performing for the first time this combination of anesthesia on peripheral techniques, neuraxial and peripheral block. And if we perform the block in continuous, that's the second postoperative day without opioids, drugs. Patient is able, of course, we have a physiotherapist available that can follow the patient, but that's important that the movement is equipped by patient, and the analgesic regimen is very, very good. That's a patient in second postoperative day. So a very frequent question is, so we will not perform no more the femoral block? No, because up to your expertise, anesthesiologist has to be in confidence with the technique he preferred to use. And I repeat, the continuous femoral nerve block is a very simple technique. It's a very simple technique. It needs just 12 procedures by its own to be executed with a very high percentage of success by the anesthesiologist. After the anesthesiologist will become more expert with the technique, he could be able to choose which one is better in his practice. But the most crucial concept is the patient need a peripheral block, or either in continuous or in single shot, combined to a multimodal drug strategy, because the early postoperative rehabilitation is the gold standard for the best outcome in this kind of surgery. And this is the first desire also of the surgeon. So the surgeon will collaborate with the anesthesiologist and together as soon as well as it will be able to see the success in the rehabilitation of their patient. And I repeat, it's not just the anesthesiologist's work that achieve this result. It's a multidisciplinary team. We need the collaboration between surgeon, between physiotherapists, between nurses in the ward, and it's crucial that all these figures will collaborate together to achieve this kind of result and to give the best result for patient indeed. And let's be serious. I like to conclude with these acronyms. Let's be serious mean the technique we choose to use has to be for anesthesiologists simple, effective. So simple and effective is crucial, and reproducible. So with these three criteria respected, our anesthesia plan will be always the best one. And with this, I end my presentation, And I would be very glad to see you in Roma for the ESRA Italian chapter Congress in November. And thank you for your attention. Thank you to have spent with us this time in the evening, and hope to see you soon. Thank you very much.
Thank you. Thank you, Dr. Tognu. Thank you so much for your sharing. It is very impressive. And now it is time for question and answers. Dr. Pacini, you can check. We have some questions at the Q&A box. You can check and welcome your communication with Dr. Tognu. Welcome.
Hello, everybody. I thank Ysonic and Jack Liu for the invitation to participate to this webinar. I thank you, Dr. Tognu, for your wonderful presentation, your clear explanation, and your movies. I think nowadays it's very important to perform loco-regional techniques like peripheral nerve blocks that permit the patient to move as soon as possible after the surgery. We have some questions for you, Andrea. How many days are recommended for the catheter to avoid complications like infections?
Yes, infection is not so often complication in continuous peripheral block. We have no limits in leaving the catheter in the position we got, but the several time we keep inside the catheter is 48 hours. After 48 hours, the peak of the pain is becoming to decrease, and a multimodal analgesic regimen based on acetaminophen and non-steroidal drugs is very useful combined to the continuous peripheral block for the first 48 hours. And with this combination, we can avoid quite totally the opioids request by the patient. That's and it's clear that the main role is played by the catheter, the continuous block, peripheral block.
Okay, thank you. Another question from the audience about spinal anesthesia in the surgery. Do you insert Foley catheters in your patients?
Sorry, Ilaria, in the surgery?
Yes, about spinal anesthesia in the surgery. Do you insert indwelling Foley catheters in your patients?
No. In the surgery, no, because usually are executed not major surgery procedures. So for example, the knee arthroscopy is generating pain for the patient right in the first 24 hours. And thanks to the combination between neuraxial blocks, so spinal anesthesia, and for example, adductor canal block and IPAC block with a total amount of local anesthetic, example, ropivacaine 0.5 or levobupivacaine 0.5% in 20 ml in the adductor canal for the adductor canal block, and 10 to 15 ml in the IPAC block is very effective in guarantee a very good analgesia in the first 24 hours. Of course, after 24 hours, patient is explaining how going on with a multimodal drug regimen at home.
Okay, thank you. If catheter is not available in a resource-limited setting, what's the alternative?
The alternative now is interesting to see how is growing up the mixture with adjuvant. So we can get 4, 5, 6 hours more in analgesia thanks to the adjunct of the, for example, 8 milligram in dexamethasone, or it's not easy to find, but dexmedetomidine now is quite used a lot in as adjuvant for the peripheral blocks, but of course it's not quite easy to find everywhere. So in my opinion, the best adjuvant for prolonging 4-6 hours the effect of the peripheral block is to combine with dexamethasone.
Okay, I've got a question for you. Is it possible to perform peripheral nerve blocks for patients who receive antiplatelet agents and anticoagulant drugs?
Of course, the answer is no. We can perform easily. For example, let's debate. We are not more speaking about elective total knee replacement, but maybe in traumatic surgery, if we are in the context to perform a peripheral block for a knee, we can quite easily perform a femoral and a sciatic block. Why? Because they are nerves as well as superficial in most of patients. So also under antiplatelet, anticoagulant therapy, we can available the opportunity to comprime, to get a strong compression above the site. Of course, we cannot achieve the same effect, try to get a compression on the lumbar plexus because it is a deep block. And because of this reason, I can advise to avoid the deep peripheral nerve blocks and to treat the lumbar plexus block as well as the spinal anesthesia. So the same manner to assume as well as we were performing the spinal anesthesia and on the anticoagulated patient.
Okay, thank you. An Italian colleague would like to know if can we use catheter of epidural for catheter for continuous peripheral nerve blocks.
Okay. So if we can use the epidural catheter as
I think
yes, we can do. Yes, we have to. Sorry, Ilaria, I interrupt you.
No, I think so because there's a toy needle and then the same catheter of the same material. So I suppose it is right.
Yes, it's right. I was loading because we got an interesting pediatric case report in which we are waiting with Ilaria, in which we performed an interscalene brachial plexus block using an pediatric epidural catheter, just because it's the same. Of course, there are available kits just developed for the continuous peripheral nerve blocks, but the substances is the same. So an epidural kit can be quite easy used by expert anesthesiologists. And my recommendation is always to keep in your ultrasound window the tip of the toy needle. That's the most important thing to respect. After that, you can use quite easy the epidural kit to perform peripheral block in continuous.
Thank you. I've got another question for you. I suppose that fast-track anesthesia for total knee replacement need a careful organization in the hospital. What specialists are involved in this multidisciplinary team?
Yes, I told at the end of the presentation, it's mandatory to have a multidisciplinary team in which of course, the most important is the surgeon, because we have available all these new interesting motor sparing techniques from anesthesiologists. But of course, as well as we have these modern new techniques, also the surgeon has to improve its own way to work. Surgery procedures are becoming always less invasive. And in the same way, anesthesia techniques are becoming less invasive too. So it's very important the collaboration between surgeon, anesthesiologist, and after the perioperative, the intraoperative period is very important, the perioperative period. So it's crucial the collaboration of the nurses and physiotherapists to achieve the optimization of the analgesia regimen and the fast rehabilitation program in the ward, just 24 hours after the surgery.
Okay.
These are patients that usually are walking 12 hours after surgery.
Okay. Another question. How early can you mobilize the patient or make them stand up?
The patient that you saw in the video. Sorry?
Yes, I
Yes.
suppose.
As soon as the spinal effect will end, patient is able to walk. And is able to walk, but it's very important that we have the permission to get the patient walking by the surgeon. So always ask to your surgeon, can the patient walk after? Of course, if patient has a different indication, we can quite easily avoid to perform a adductor canal block. So it's very crucial to speak with your surgeon, your equip surgeon, to understand if it's could be efficacy to treat the patient with the kind of block respect to another. If your surgeon will tell you, no, I'm not need that my patient will be walking after 24 hours, of course, I can quite easy perform a continuous femoral block with a strong concentration, always to achieve the best analgesia, also achieving the motor block of the patient. But I'm not interested because, of course, if patient doesn't need to walk after 24 hours, I can push my peripheral blocks as heavy as I can.
Okay, another question. What is your opinion about performing genicular nerve block plus EPAC instead of femoral or saphenous nerve block plus EPAC in TKA? I suppose is a total knee arthroscopy or total knee
No, it's total
surgery?
knee, total
Okay.
knee. I think less is more always. So if you have to perform the genicular block, the IPAC block, of course, you have to perform also the spinal anesthesia. So if I have to perform spinal anesthesia, I prefer to have an adductor canal block performed because it is very easy. It is very, he's got a lot of efficacy in achieving a long-lasting analgesia after surgery. Moreover, if is not the case of arthroscopy, but if I need to place a catheter, it's very easy to place a catheter in the abductor canal. The genicular is, I have to perform two puncture, I mean just the femoral genicular, because if I perform the IPAC, I don't need the other genicular. But in my opinion, the simple technique is the best one. And moreover, I prefer to use a technique that stay away from the operation site, from the surgical site. Sometimes you will have some surgeons not liking so much that anesthesiologists would be perform the EPAC block. Why? Because the EPAC block is an injection right in the surgeon site. So if there will be occasionally an infection after surgery, who is the guilty? The EPAC block or something else? Moreover, that's just to debate. EPAC block is very useful technique. You can achieve a balance between surgeon and anesthesiologist. If your surgeon doesn't want the anesthesiologist to perform the EPAC block, you can ask the surgeon to inject the posterior capsule of the knee just during the intraoperative time. But coming back to the question of the colleague, performing spinal anesthesia for knee arthroscopy, I would be rather in confidence with the abductor canal and EPAC more than in performing the genicular nerve block.
Okay, another.
But good question.
Can you practice fast-track anesthesia in chronic pain patients? I think so.
Yes. Fast track is a perfect multidisciplinary regimen amongst more figures, and chronic pain patient is maybe the best one to treat with a fast track. And moreover, I can argue that a patient with chronic pain is very probable already treated with a lot of drugs to contrast the pain. And it's interesting how this early management with several drugs to contrast pain can have a very good effect combined with the peripheral block during the surgery.
Okay.
But anyway, remember, fast track in its definition means that you have to give your patient the best quality of life and coming back to normal quality of life in 48, 72 hours.
Okay. Another, which device is better for a continuous adductor canal block for you? Over needle device, through toy needle device, or through split cannula device?
Okay. Do you have available all these devices? If you have available all these devices, up to you, the better for you. This is my opinion. In my practice, I love the toy needle. I guess is the best one. Why? Because we can perform the hanging needle technique, and that is very crucial in obese patient, because for didactical scope, I showed to you all very clear imaging videos made on thin patient. But we know very, very well how heavy are our normal patient. Moreover, the candidate to the total knee replacement. And the use of a toy needle allows to anesthesiologists to manage in the best way the catheter positioning, also and particularly in very obese patients, for to be treated with the abductor canal block. So in my opinion, toy needle. The catheter oval needle is very useful just for the very superficial nerve structures. So maybe interscalene, femoral, but the limit of these devices is the depth of the structures. That's all.
Okay. And now a question that I can imagine make you happy. Can you share experience plexus lumbar block for surgery lower extremities?
Yes, a lot.
You are an expert.
Yes, yeah. Yes, I'm very expert in lumbar plexus block, and I can quite easy. I've been performing in last 15 years lumbar plexus. Lumbar plexus is a very, very powerful block, satisfying block for anesthesiologists. It can give you the solution when you are obliged to avoid general anesthesia or neuraxial anesthesia, of course, in managing of the lower limb surgery, in traumatic patient, in anticoagulated patient, antiplatelet drug treated patient. Lumbar plexus is a block that need to be in confidence with, and combining the lumbar plexus block to the sciatic nerve block, you can keep the anesthesia management for all the procedure of the lower limb. Up to you if you want to perform it in continuous or not. In the past year, we were performing the lumbar plexus in continuous. After many years of experience, we avoid now to place catheter in lumbar plexus. We just perform the lumbar plexus in continuous for major cancer surgery. Major cancer surgery of the lower limb is the only right indication, in my opinion, to perform the lumbar plexus in continuous. But if you are in confidence with this kind of block, you never leave it. It's very, very simple, more than epidural sometimes. And it depends to the experience of each one. But I repeat, if you have available a good experience with epidural neuraxial block, with lumbar plexus block, with parasacral ischiotic block, you can have for every kind of surgery, of lower limb surgery, really quite easy.
Okay. Another one. Can we do saphenous block by nerve stimulator?
No, unfortunately not, because it is just a sensitive nerve. The very expert could try to, but you don't need, because it is a block that really that rely totally on the ultrasound guidance. But if one could try, could stimulate with a very high amperage in the place where the tip is located once we have found the right place, and ask to the patient if it's feeling sign of a seizure on a paresthesia on the leg. But it is really not necessary. It's just to debate for the answer. Definitely, saphenous doesn't need the nerve stimulation. Totally.
Okay. Another one. Can large volume adductor canal block be used as a single technique for analgesia for both anterior and posterior knee? What about the volume you use?
In literature, the Thomas Benson, that is the more expert in this technique, says you can use quite easy 10 amount in the initial part of the abductor canal and 10 in the distal part of the canal. In my opinion, now that we have available the EPAC block, the best solution is share the amount of local anesthetic both in the abductor canal and in the EPAC for the EPAC block. And the total amount that we have available is up to the patient, in the normal weight patient, up to 40 ml, 0.5 concentration of long-lasting local anesthetic. Remember that if you are injecting local anesthetic right in the abductor canal block, you can inject till 40 ml of local anesthetic without having motor block. And of course, maintaining a safe plasmatic concentration of local anesthetic.
Okay, thank you. The last one. Do you have a cutoff BMA for fast track anesthesia for obese patients, or it is the same as for day surgery?
No, right. This is a right question, because of course we cannot remember the AMI, arthrogenic muscular injury. So the damage of the tissues because of surgery. We have a cutoff about 35 BMI, because of course if a patient is heavier, is more than this BMI, is more probable that the implant, so the total knee replacement implant, will be suffering in the perioperative time, in the postoperative time. But this is a decision that we manage together, of course, with orthopedic surgeon. If for surgeon is okay, we can quite easy manage also more than 40 BMI. But the real cutoff should be 35.
Okay, another one. When do you start a ductal canal infusion? Do you start it right after the surgery, or do you wait a few hours?
I replied to this answer with a question. Which kind of infusion you manage for the abductor canal block? I explain myself. If we perform a single shot, even before place the catheter, if we inject 20 or 30 local anesthetic ml, maybe ropivacaine or levobupivacaine, is suppose the analgesia will be long-lasting till 15, 20 hours, quite easy. And after this period, what is better? To program a strategy infusion or a bolus injection through your catheter in the adductor canal? It's interesting because the abductor canal block is a volume block. So we need an important amount of local anesthetic to fulfill this abductor canal. In my opinion, a very easy way to manage the continuous canal block is to start with a second injection after 15, 20 hours from the first one. And if you have not physician available or nurses available to inject the second dose in local anesthetic, you can, but of course, in not always is available, you can perform the infusion through the bolus, through the pump infusional system.
Okay.
Okay, Dr. Tognu and Dr. Pacini, thank you so much for your question answering with our participants. I think our today question and answering time is over here. Thank you so much. Thank you, Dr. Tognu and Dr. Pacini, for accepting our invitation to share your course here and help us with so many questions in detail professionally. And also, we really appreciate the participants all from global anesthesiologists. Dr. Tognu and Dr. Pacini, do you have any questions?
I'm curious, how is the real fast track protocol adopted in your reality in Shenzhen or in China?
I would love to know that, but I don't have this kind of knowledge.
Because, for example, in Europe is not in every place. You cannot see everywhere this kind of manage. So is right 10% of the hospitals. So we need to grow up with this mentality. We need a lot of collaboration, meeting between experts, surgeon and anesthesiologists and physiotherapists. We need to communicate more and more.
Very good. And we also have planned to organize what we call a forum to organize European experts together with Chinese experts to communicate. I think we can organize this kind of activity within this year. So welcome to join us, to share with us. Okay.
Of course.
Thank you so much for everybody. For more information about WISonic new webinars, and please follow up WISonic public account on Facebook or LinkedIn. Thank you so much. I think everything is. I think our time is going so fast. And now it's time to say goodbye to everyone. Thanks so much.
Good dinner.
See you soon. Thank you.
Have a good dinner.
Bye.
See you soon.
Bye. Have a nice day.
You too. Thank you, Jack.
Bye. Thank you, Dr.
Ciao, Ilaria.
Bye.